Good evening, everyone. Welcome and thank you for joining us for tonight's webinar, Sanitiser, SUDS and COVID-19, including its effects on substance use in the community. This is an initiative of the Queensland Regional and Trainees Committees. My name is Tracy Handley. I'm the Senior Executive Officer for the RACP in Queensland. I would like to start this evening by acknowledging the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. I would also like to pay respect to elders both past, present and emerging, and together we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education as core business of the college. From the RACP, you have myself, Amity Kruger, the Executive Officer, Hannah Parker, Member Support Officer, online from the Queensland Regional Office. We also have Samuel Detman, Senior Policy Officer from the College Policy and Advocacy Unit, to help with any questions that you may wish to submit through the Q&A function. I will now hand over to Natalie from the RACP events team, who will be assisting in the facilitation of this evening's webinar. Thank you, Natalie.
Thank you, Tracy. Before we get started, I would like to go over a few items so you know how to participate and interact during the webinar. You have joined the presentation using your computer speaker system by default. If you're having trouble hearing, please select the correct speaker device. You can do so by selecting the arrow next to the microphone located at the bottom of your screen. You will have the opportunity to submit text questions by typing them into the Q&A function of the control panel located at the bottom of your screen. You may send questions through at any time during the presentation and they will be addressed at the end. Please use the chat function for any technical issues you might encounter. Any questions to the speakers using this functionality will not be addressed. Please be advised that the session is being recorded. Communication will be sent by email next week containing a link to the recording, a copy of tonight's presentation slides, details on how to claim CPD for RACP members, and a compilation of all questions submitted with relevant answers in the instance that we do not have time to answer all during the webinar tonight.
I would now like to introduce the first presenter, Dr. Jeremy Hayllar. After training in general medicine and gastroenterology in London, Jeremy was looking for a change. Together with his wife, he travelled to Mount Isa in 1992, lured by an image of Whitehaven Beach in the Whitsundays on the back cover of the British Medical Journal. He spent 10 years in Mount Isa Hospital as Director of Medical Services and being a general physician. In this hard drinking mining community, his interest in substance use problems developed. Since 2004, he has been Clinical Director of the Alcohol and Drug Service, Metro North Mental Health. His interests include treatment of opioid use disorder and the interface between addictions and mental health. He is currently researching CYP2DC activities in patients who have developed opioid use disorder from codeine. Over to you, Jeremy.
Thank you very much, Tracy, and welcome everyone. Thank you so much for joining us this evening for really a talk around addiction medicine and the impact of COVID. I tried to make the title a bit of a tease. I hope you were intrigued by that, and as we go through, I'll explain what I was thinking. There are a few disclosures there, but I try to avoid being influenced by pharma. So I hope these views that I'll express are my own and not representing any other, certainly pharmaceutical companies. So we'll talk initially about the effect of substance use on COVID-19 vulnerability, the risk of disease severity. And happily, a couple of papers have arrived just this week, which give a lot more substance to this question. Previously, it was largely speculation. And then we'll talk about the effects of the pandemic on substance use by people in Australia in particular. And I've put the list of substances down there. And we'll touch on the dark net, which has had quite a lot of publicity in recent months. We'll touch on the National Drug Strategy Household Survey, which just gives us a snapshot of where Australians are at in terms of substance use. and a couple of thoughts on market forces and psychosocial stressors. So this paper from Fried et al. Came out at the start of the month, and they looked at over 11,000 patients admitted with COVID-19 in the States, about 200 hospitals, I think. And what seems remarkable is there were really only two chronic disorders which seem to increase the risk of death. I've highlighted those, chronic kidney disease and cardiovascular disease. And more surprising really is hypertension does not seem to be associated with an increased risk of death, and nor does smoking. Sorry, this is my mouse going crazy. Nor does cigarette smoking. You can see there the second row below obesity, which barely covers the 1.0 odds ratio. So even obesity doesn't seem to come out too badly, despite what has been claimed in the press and in earlier reports. So this paper from the BMJ, from Molecular Psychiatry just this week, looked at 73 million people's electronic health records in the States. These people served by 360 hospitals with data collected up to mid-June. So of those 73 million people, 10% or so had had a diagnosis on their EHR of a substance use disorder. In total, there were 12,000 or so diagnoses of COVID-19, and 15.6% of those diagnosed with COVID had a prior diagnosis of a substance use disorder. That total was 1,880. They then followed through what happened to patients who went to hospital. The risk of hospitalization was increased in those with a substance use disorder compared with those without, as was the risk of death. You can see 9.6% against 6.6% of those without a substance use disorder. The strongest effect was seen for opioid use disorder and then tobacco use disorder. So that is rather at odds with the earlier paper slide I presented from Fried. Nevertheless, this is a huge amount of data that's been collected, so I think we have to give it credence. So to try and sum up the effect of substance use on COVID-19 vulnerability, we know that people who drink heavily, alcohol heavily, have a 2 to 3 times increased risk of pneumococcal pneumonia. So we'd expect some similar vulnerability to apply with COVID. Tobacco smoking, as we've seen, is a little more complicated. CDC recognizes smoking as a possible risk factor. We've heard a lot about angiotensin II receptor expression. That's the route of entry of COVID into the cell. We know that nicotine may increase receptor expression. There's a lot of dispute about whether that's really relevant or not. There's a 1/3 increased risk of self-reported COVID in smokers and ex-smokers. So that's recently published data. However, we've seen here the risk of COVID death on the last 2 slides may be lower or may be increased. So where things are at, well, we need more information. It seems fairly self-evident, I think, that opioids, which can impair immunity, constitute a risk factor. And we saw that in that data from the States. And now there's a big paper being published in the British Medical Journal this week doing a risk stratification, recognizing the importance of comorbidities. And included amongst those comorbidities are cardiac, respiratory, renal, hepatic, cognitive function deficits, as well as connective tissue disorders, diabetes, HIV, malignancy, and obesity. So they're really recognizing those comorbidities as relevant for prognosis in COVID-19. And many of our addiction-related patients will have one or more of those comorbidities. So I think the connection is pretty clear. The exact extent of the risk increase is still in doubt. Now, this was a study of illicit drug users who were responding to a questionnaire about what they had done in terms of substance use during the early part of COVID. The data was collected and published in June. So as we can see on the left, cannabis seemed to be the substance with the most dramatic increase in use. In dark blue along the top are those who increased their use, and in medium blue at the bottom are those who decreased their use, and in the middle we have those whose use was unchanged. Really though, there's nothing too dramatic here, I think you'll agree, and this is a select population using illicit drugs rather than the general population. So do we regard alcohol as an essential item? I think in Australia we probably do. And because of the closure of restaurants and bars during COVID, the licensing restrictions were very rapidly lifted to allow these venues to have off-premises sales of alcohol. The only state or territory which took the other view was the Northern Territory, which actually increased the restrictions to discourage gatherings. New South Wales acted within hours of closing all these venues to change the regulations. And actually the police were caught out. They went to try and close down a premises which was doing off-premise sales, and were then advised that the law had been changed. We know from Commonwealth Bank card data that online sales escalated dramatically in March by about 30% compared with March 2019. However, in April and May and subsequently, sales dropped back. So that really suggests that people were stockpiling alcohol and not necessarily drinking it. At the same time, online sales were boosted dramatically. And we have some concerns with this because there's less regulation. So there's no enforced age limits on purchasing. Fewer than 20% of websites refuse delivery to those who are inebriated or underage. And about a fifth of users' motivation to purchase online was that they felt they were over the limit to drive. So it's perhaps could be argued these people shouldn't be receiving more alcohol when they're already perhaps unfit to be served in a licensed premises. Now, Retail Drinks Australia introduced some very philanthropic voluntary purchase limits. I've put limits in inverted commas because, in fact, their limits amounted to about 220 units of alcohol in any one visit for any one individual, which, according to the currently undergoing revision guidelines, would be about 5 months' supply of alcohol. WHO suggests restrictions should be upheld or reinforced during COVID because of the risks of close downs on domestic violence and other factors in the home. So I think overall consumption hasn't changed dramatically. This is just showing from WA, the WA government introduced restrictions which at 60 units per visit to a licensed premises seemed fairly generous. Then Retail Drinks Australia came in with its recommendations, and Western Australia quietly dropped its own restrictions. So this is a good example of a big alcohol at work, I'm afraid. Just to refresh our recollections of the guidelines for reducing health risks from drinking alcohol. In 2009, on average, it was 2 standard drinks or 20 grams of alcohol per day, 14 per week, same for healthy adult males and females. And in 2020, the draft guidelines, which are currently being reviewed, they will no doubt, I think, drop that weekly consumption to 10 standard drinks. So based on their method of calculating risk, which is a risk of death at less than 1 in 100, they've reduced the weekly amount for low risk drinking to 10 standard drinks. So this survey was done by the ANU Centre for Social Research and Methods. Over 3,000 people across 18 data was collected between April and June. And a bit like we saw with the illicit drug use in that earlier slide, about 20% of people had increased their alcohol intake and over a quarter had dropped it. Of those reporting an increase, I think this is important, 50% said it was 1 to 2 units per week, and 25% said 3 to 4 units per week. So in the big picture of things, these changes are pretty minor. Of women who increased their alcohol, it was mostly those doing home duties and childcare, where over a quarter had increased. In contrast, the men, it was those who were dropping their work hours who'd increased alcohol. In both genders, stress was a strong predictor. Just sort of showing the validity of this survey, the smoking prevalence in this group surveyed was 11.8%. We know from national surveys last year that the smoking prevalence is now about 11%, so a pretty reasonable tally there. Some of those questions had used illicits, about 12%, and less than a fifth had increased their use and about a quarter had reduced their use. So we're seeing a bit of a pattern with some people feeling they've increased, some people reducing, and some people staying about the same. This slide shows what happened in India, where they had a national complete lockdown in mid or late March, the 22nd of March. And this is from one hospital in Bangalore, where the number of patients presenting with severe alcohol withdrawal syndrome escalated dramatically, compared with data which you can see in green from 2019. And what we can see too is that as the 3 weeks neared completion, the number of presentations for alcohol withdrawal fell to 0. So it's a very nice illustration of the effects of stopping alcohol suddenly and then having no available supply. Also reported in the press were suicides because of unavailability of alcohol, liquor theft, and methanol poisoning, which we'll come to. Interestingly, the authors note that some of the symptoms of alcohol withdrawal, severe alcohol withdrawal, fever, vomiting, tachypnea, may mimic those of COVID-19. So there was a difficulty in separating out who exactly had what. Most of these severe cases were discharged within 36 hours, which is a very short time in hospital. And one does have concerns about the fate of those patients. Just a note from South Africa, which also had an alcohol ban, they suggest that about 5,000 fewer emergency department visits resulted from the reduction in domestic violence during the lockdown with no alcohol available. So I mentioned methanol a couple of times. Here we have from August a report from the States of serious adverse health events, including death associated with ingestion of alcohol-based hand sanitizers. There's an illustrative case. You can see a 44-year-old man being evaluated after recent onset of visual impairment. He reported drinking an unknown quantity of alcohol-based hand sanitizer during the few days before seeking medical care. Initial labs showed a blood methanol concentration of 97, so that's about 0.25% in breath alcohol terms, so 5 times the limit, and a metabolic acidosis with an anion gap of 32, serum bicarb less than 6, and a pH of 7.09. His clinical course was complicated by seizures. He was treated with fomepizole, which we'll come to, and hemodialysis. After a 6-day hospitalization for acute methanol poisoning, he was discharged with near total vision loss. So this is their brief summary of 15 patients who had methanol poisoning after swallowing hand sanitizer containing methanol. So 4 deaths, 3 with visual loss, 4 remaining in hospital, and 4 discharged without complications. So clearly this is a big deal. What I've been able to determine is that sanitizers in Australia do not contain methanol, as we know that methylated spirits no longer contain methanol, a public health initiative dating back to the 80s. Just to remind you of the metabolic pathways here. So ethanol is broken down by alcohol dehydrogenase to acetaldehyde. In turn, aldehyde dehydrogenase degrades acetaldehyde to acetic acid. This is a very efficient reaction. And when one takes disulfiram, or antabuse, the trade name, to inhibit that enzyme, this leads to the accumulation of acetaldehyde with very unpleasant consequences of flushing, vomiting, and diarrhea. So it's an aversive way for patients to avoid alcohol. If, on the other hand, you've ingested methanol, for example, from a hand sanitizer, then the alcohol dehydrogenase produces formaldehyde, sorry about this, which in turn, through aldehyde dehydrogenase, is metabolized to formic acid. This is the toxin in ants that protects them from predators. Formic acid in humans causes metabolic acidosis, blindness, and coma. And I mentioned fomepizole, which is given by infusion, that inhibits alcohol dehydrogenase. So that slows down the breakdown of methanol and the production of formic acid. So despite that treatment being given to the index case that I described, blindness still resulted. So this is a serious consequences. And often it's described in home brewed liquor when methanol has been the unwanted product of home brew. So just to come down to earth with a patient I've been seeing, she's a registered health practitioner who was suspended because of a DUI while driving to work after the school run. APRA conditions, she notified APRA, of course, included breath alcohol readings at the start and end of day shifts. She was only allowed to work day shifts. However, at this time, the hospital she worked at suspended alcohol testing, breath alcohol testing, because of the risk of droplet or respiratory spread. And although you can measure a passive reading by just breathing over the alcohol monitor, this does not meet the current APRA requirements. So this standoff, including us advocating for the patient and saying, well, couldn't she do it in the car park? Couldn't she do it in the open air? It took over 4 months to resolve. We finally got agreement with the patient supplying their own approved alcohometer to do the measurements. The lack of face-to-face consults with phone calls and emails, it just made it all a bit more challenging, as you can imagine. And we tried a range of anti-craving medications, and they hadn't really been effective. So in the end, the patient agreed to start disulfiram. And then the next panic was, if we're giving disulfiram to inhibit acetaldehyde dehydrogenase, what is going to happen with the widespread use of alcohol-based hand sanitizer? There was a case report of a gentleman going into a bank where they had a hand sanitizer dispenser by the entrance. He cleaned his hands and in the process inhaled the vapor from the alcohol sanitizer and developed a disulfiram reaction. So that made it to be a case report. And this patient was very worried because she couldn't see how she'd be able to work unless she was able to sanitize her hands on a regular basis. Happily, at around this time, a report came from London. Is alcohol in hand sanitizer absorbed through the skin or the lungs? And warnings about the absorption of alcohol through the skin from hand sanitizers and products such as perfumes, deodorants, and aftershave should be modified, because the evidence is it's actually the inhaled alcohol from the sanitizer which leads to the absorption, not through the skin. After all, keratinized skin is slow to absorb things, as we know from nicotine patches, for example. Now we're moving on to illicit drugs. There's something very special about illicit drugs. If they don't always make the drug user behave irrationally, they certainly make many non-users behave that way. This is from a Harvard psychiatrist. So here's a bit of fake-ish news from Crikey. They're saying cannabis use soars during the pandemic. What they're actually talking about is TGA approvals for medicinal cannabis, which were streamlined about 13 months ago. And during that time, there's been an increase in applications and approvals. Let us not forget, though, that nearly 12% of the adult population have used street supplies of cannabis in the last 12 months. One of our patients advised they had quit cannabis because of the New South Wales border closures. They were unable to travel to Nimbin for their usual supplies. For information, Nimbin will do mail order, but you do risk your product getting seized. The risks seem fairly low. So I thought I'd look at the TGA website and see what had actually happened. And this is cannabis use soaring. So this accounts for less than 5% of overall cannabis use. And you can see there's a sort of reasonable increase perhaps from May. But I think this is largely because the process were being streamlined and there was growing knowledge and awareness. So GPs in particular were being asked by patients to be prescribed. So if we move from cannabis to methamphetamine, we've got a good study from Perth that was published just at the start of the month. The COVID pandemic constricts methamphetamine supply. The price went up from $30 to $100 per point, which is 100 milligrams, with a significant decrease in methamphetamine availability and quality. And so what we can see here is in 2020, between Q1 and Q2, the price going up dramatically and the number of dealers dropping significantly. Availability and quality going very dramatically down, as you can see on that graph on the right. So to touch briefly on stimulants and our services, at Hayllar in Roma Street, we have a needle syringe program distributing about 1.5 million packs per year. That means about 140 people per day pick up supplies. And certainly in February and March, with the impending shutdown, there was a dramatic increase in demand. We generally supply up to 100 1 ml insulin syringes and 20 butterflies per user per visit, plus water for injecting and alcohol chlorhexidine swabs, which unfortunately are more often used after the injection than before. So that's a point for stressing when these supplies are being issued. Wheel filters are also available at a small cost of $2. The proceeds are now being used to purchase naloxone for supply to people who inject drugs. Methamphetamine price, certainly in our service, we're told it's increased from $50 to $100. And a number of users say because of the price rise, they've switched to heroin. So there's a sense that people want to be in an altered state and they're not too choosy whether it's the stimulant effects of methamphetamine or the kind of opposite effects of heroin. Anecdotally, we've seen several patients using cocaine presenting, which hasn't really been a feature until 2020. So I thought I'd present this chap who turned up 2 weeks ago in clinic. He used to be a hairdresser, but he said that was boring. So now he describes himself as a consultant, and he's on parole because the police recently raided his dwelling and found methamphetamine. He's been using for 15 years. He no longer uses alcohol. He's quit tobacco. In the past, he's had episodes of psychosis. And he says, although he loves his sleep, he only has 3 or 4 nights a month when he sleeps properly. He's got no usable veins left, and his theory was that something's been added to methamphetamine to ruin the veins. It's probably the methamphetamine itself that does that. So instead, he has a neck doctor, he describes, who accesses his neck for injection use. He also has a dark net operator via whom he does business in Melbourne and Sydney, and these are the main sources of supply for Brisbane, it seems. Supplies coming through various routes to Brisbane from the main cities of entry. Now, China used to supply most of the methamphetamine coming to Australia, and COVID-19 closed that down completely. And apparently there were international bargaining and wars between suppliers, and Mexico apparently has taken over. And their product smells like salt and vinegar crisps, so that's what it's been termed. These suppliers are very canny businessmen, so they saw coming a real cash storm with early access to super, both last financial year and this financial year, with tax rebates at the end of the financial year and job seeker payments. So this has been described as the check effect by Hodge et al. And they show that in the 2 days after receiving a check of a benefit or other payment, increased IV use 1 to 2.5, well, 1.8 to 2.5% times increased use. So an interesting phenomenon there. What my consultant described here was an ounce of methamphetamine, the normal price would be $3,200, went up dramatically, reaching as much as $25,000. And it's now fallen somewhat, but it's still grossly higher than had been the case only a few months ago. In contrast, cocaine, which is usually regarded as the kind of luxury product, is just $6,200 per ounce. So this man is now contemplating life without methamphetamine, which he feels is treating his self-diagnosed ADHD. And that does present a diagnostic dilemma, I realize. So this is a picture from Wuhan, and 8 lanes of highway completely deserted. And we know of Wuhan because of the COVID-19 source, allegedly. Maybe that's the case, maybe it isn't. What is also produced in Wuhan in large quantities is synthetic opioids, fentanyl. So that may have closed down some of the fentanyl business as well. Fortunately, Australia has been relatively spared, but we nevertheless have significant problems with opioids in this country. So I've then thought we should just touch on the treatment of opioid use disorder. In Queensland, we've got about 7,000 patients on opioid treatment. Around 60% are on buprenorphine products and 40% are on methadone. In total, there are 50,000 on treatment in Australia. In Queensland, about half the patients are managed with public clinics, the rest are in private hands, and most of the dosing is at retail pharmacies. A recent paper shows that about 15 years of life are lost by people with an opioid use disorder. So this has major repercussions. We've got about 1,000 patients on opioid treatment across 4 clinics in Metro North. As I mentioned, methadone, it's now 50 years since methadone became available for opioid treatment in Australia. Stella Dalton in Parramatta was the first person, a psychiatrist, which is very touching. Buprenorphine, we have Suboxone, that's the combination product with naloxone, and Subutex, which is buprenorphine solo. So the Suboxone is preferred because there's a lower likelihood of it being diverted or injected. And in the last 18 months, we've had long-acting injectable buprenorphine, which means people need only dose weekly or generally monthly, which has meant a revolutionary change for many people away from the supervised daily dosing, which is the principle of opioid treatment, with kind of concessionary takeaway doses as a reward to patients for good behavior. So our current guidelines say we should limit to 4 methadone takeaways a week, taken by someone who's opioid naive. Methadone is clearly dangerous and you don't need a big dose to overdose, and a child getting hold of it would overdose with a very small dose. Suboxone, because it's a partial agonist, is much safer, so up to monthly takeaways are allowed, achieved in stages. So one of the attractions of the long-acting was that it would reduce the need of patients to go to pharmacy for their doses or attend clinics so regularly. So in our service, we now have about 100 patients on the long-acting products. And typically those stable on buprenorphine naloxone can switch to weekly or usually monthly dosing with subcutaneous buprenorphine in a fluid crystal matrix, which has this solvent N-methyl-2-pyrrolidone, which has caused some controversy about whether it's teratogenic, though these animal studies use very high doses with daily exposure, whereas evidence from these products is that the dose being provided of the NMP is quite low, and it's only present for 24 hours of the month of the injection. So overall, our patients have been very positive about the long-acting, and we've probably got 85 to 90% of those who started out are still on the long-acting treatment. So very good adherence. The cost is greatly reduced. If they come to clinic for the treatment, they don't have to pay. The convenience is greatly enhanced. They don't have to turn up to pharmacy regularly. And it gives very good coverage, both of cravings and blocks on top opioid use. So some services, not I think in Queensland, but down south, made their patients change onto the LAIB because of COVID. We preferred a collaborative approach, promoting choice and autonomy for patients and deciding on increasing takeaways on an individual basis. I must say, though, in the custodial setting, the long-acting buprenorphine is a very attractive option. Although that may limit the choice, it certainly seems to improve the function in jails. And that's been experienced from New South Wales, where currently there are over 800 patients in jail on long-acting products. So one of the headlines recently, pharmaceuticals kill more Australians than illicit substances. Each year, the Pennington Institute produces an overdose report. So the latest 2020 was published just a couple of weeks ago, and that refers to data from 2018. So this is one of the summary slides, 900 opioid deaths. Now, many of these deaths are not a single substance, they're polysubstances. So the dominant substance is that which is attributed the cause of death. If we move round the circle clockwise, benzodiazepines next, stimulants next, which have risen dramatically in recent years. And then antidepressants, cannabinoids, and those typically are synthetic cannabinoids rather than the more natural product, if I can use that word advisedly, then antipsychotics and anticonvulsants. So the big picture items are really those first three: opioids, benzodiazepines, and stimulants. Of the opioid deaths, under half are heroin, and a growing number are prescription opioids. And the total number of deaths in Australia now exceeds the road toll each year. That road toll has been falling, whereas overdose deaths have been increasing. It's timely, I think, to mention opioid antagonists, which can be used to reverse opioid overdose. So we now have a choice of products, and I must say the arrival of Nixoid, which is an intranasal delivery of a 2 milligram dose, is very welcome. As you can see, the 2 milligram is in very concentrated form in 0.1 mil, whereas naloxone in the form of Narcan is typically 0.4 milligrams per mil for intramuscular administration. So both products are very effective with reverse overdose. They have a high affinity. They are full antagonists. They have really no other pharmacological effects. They work at mu, kappa, and delta opioid receptors. They're short-acting, which is sometimes a catch. If you've got someone who's overdosed on a long-acting opioid agonist, such as methadone, then there may be a temporary reversal of overdose with naloxone, which then wears off and the methadone reasserts itself. So that's very much a cautionary approach required, and often a naloxone infusion is needed. Limited oral bioavailability, hence Suboxone, which is the combination, and Targin, which is oxycodone plus naloxone 2-to-1 ratio. And that's how we generally treat patients who have a greatly diminished respiratory rate and are developing hypercarbia. So someone who's simply very drowsy, we don't encourage use of naloxone because precipitating withdrawal in such a patient will be very aversive. And some people might think that such approaches will reduce the likelihood of further overdoses. I'm afraid that's not really been borne out by evidence. Most people aren't overdosing intentionally, so they come to the attention of ambulance and emergency departments because of an accidental overdose. Just a side note, there's another reversal agent called Dipranorphine or Revivon, which is always supplied together with etorphine, which is an extremely potent opioid, just really available in veterinary practice. 4 milligrams of etorphine are enough to drop a 4-ton elephant. And because of its strength, those initially researching etorphine made the mistake of using a glass stirrer to stir their coffee, which had been in contact with the etorphine. And 3 of the scientists developed overdose and had to be treated in the lab. So a dramatic lesson there of the potency of etorphine. So I'm now moving on to depressants, and I like this headline from the New York Times. Prozac Nation, which takes us back to the 90s, is now the United States of Xanax, one of the trade names for alprazolam. Although Xanax is no longer sold, at least by pharma in Australia, Pfizer have them withdrawn from the market because of reputational damage. So I'm talking here just touching on a range of depressants, so benzodiazepines, Z drugs, gabapentinoids, which are growing more and more worrying as an added mind-altering or alternate state-producing medication, and also GHB. So if we think about street benzos for a moment, there's a growing range of potent analogues being identified by toxicology, including recently etizolam. And as I've shown you, 700 fatalities almost from benzodiazepine overdose in 2018. To turn to GHB, the cost has increased significantly, generally 2 mils, and you've seen those little soy sauce bottles. They contain 2 mils, they're called the fishy. That is enough for achieving an altered state. And there's been a growing use of GHB in young people, often together with methamphetamine, for reasons that are not self-evident, I have to say. It's probably got the lowest therapeutic index of any psychoactive product, 5 to 8 to 1. And for loss of consciousness on its own, which many GHB users will admit they've suffered, often on multiple occasions, this ratio may be only 2 to 3, although patients do people rapidly develop tolerance. Some users write G on their hand and set an alarm to space the dosing each 2 hours, so they remember that they shouldn't use it any sooner because memory can be affected. We've got a patient now who's getting his supplies from overseas. It seemed magically to treat his autism spectrum disorder, only temporarily, of course. And then his last $200 sent to Ireland, COVID struck, and his supplies drew up. So he presented to us with withdrawals, and we've now nearly completed a protracted withdrawal process. I mentioned the crypto markets. This is probably more in the headlines than in reality. So Silk Road, you may have heard of, that was closed down, then a number of others.
5 minutes.
Australia,
thank you, Jeremy.
Thank you. Australia had the second highest number in 2017, but things may have changed. Australia Post delivers 40 million parcels a year, 35,000 border force detections, so pretty low rates of detection overall, though of course all those parcels don't have drugs. There's some positive feedback until recently when, as you can see on this graph, this comes from the EU, lots of the markets are closed down very quickly, and you can see scam or voluntary or hacked or unknown to many of the markets. So really this does seem a fairly fragile process overall. I've listed here bulk buys, and that is for your interest and may repay further study. I'll just point out the mean income for the people who responded to the questionnaire. This is from needle syringe users was $411, and the mean amount spent the previous day was $140. So do your sums and imagine what may be happening. National wastewater drug monitoring, also detecting COVID-19 RNA, of course. So we've got an intersection between two screening programs in process. And interesting reading from that. The National Drug Strategy, I mentioned smoking at 11%. There's still 21,000 tobacco-related deaths per year in Australia. We've got a strong socio-economic gradient too, with North Sydney at 5% up to North Queensland at 19%. Alcohol, 25% drinking at risky levels, at least monthly. About 10% of the population have the criteria for alcohol dependence. And 40% of the population in total have ever used an illicit in the last 12 months. That's over 11% cannabis, cocaine, MDMA, methamphetamine. And heroin there you see is almost an after run. A significant proportion using non-medical pharmaceuticals, though codeine has dropped by 50% since it was rescheduled, so no longer available from over-the-counter sales. Aboriginal and Torres Strait Islanders, daily smoking 27%, that was 35% in 2010. And also a reduction in risky alcohol use, which is very positive. Psychosocial stress, well, many patients have avoided hospitals because of fear of contagion. Our patients have added reason, having had often very negative interactions with health services. So I ask you to beware the seductions of deservingness, who is more deserving of care. Many patients have trauma histories, particularly childhood adversary. This predisposes them to both substance use and mental health disorders. There's a widespread stigma against drug use in the community. Often there's accommodation issues and overcrowding, employment problems and legal issues. So it's a veritable storm when you add COVID-19. So in opioid treatment in particular, we have an aging cohort with opioid dependence, making them much more vulnerable to COVID-19 because of a range of comorbidities. I think many of the COVID-19 effects on drug use have been hyped. There are still many studies in progress. Most dramatic has been the influence on methamphetamine. We're now getting the salt and vinegar through from Mexico, so no doubt prices will drop in coming months. Online sales of alcohol weren't really matched by a dramatic increase in alcohol consumption. Alcohol-based hand sanitizer is safe, as long as you don't use it in a confined space when you're on disulfiram. And I must say, addiction is a fascinating, dynamic and rewarding area to work. So thanks very much for listening. Dr. Gail Robinson will shortly show you how. Thank you.
Thank you so much, Jeremy. I just want to remind everybody that they can ask Jeremy questions through the Q&A function, which you'll find by hovering at the bottom of your screen. So please feel free to post your questions there, and Jeremy will answer those whilst Hannah and Gail do their presentation. So I would now like to welcome Associate Professor Gail Robinson. Gail is a Director of Medical Services, Metro North Mental Health, and a Clinical Director at the Prince Charles Hospital, Brisbane. Gail has extensive experience as a consultant, clinical director, and researcher. Gail is a Fellow of the FRACP Chapter of Addiction Medicine, as well as having 3 other fellowships. She was Clinical Director of Addiction Services in Auckland and continues to promote addiction training and workforce enhancement, and has been a member of the FRACP Queensland Regional Committee since 2016. I'll also introduce at this point Hannah Parker, the Member Support Officer for Queensland, who along with Gail will talk about the training opportunities with the FRACP Chapter of Addiction Medicine. Over to you, Gail.
Thanks, Tracy, and thank you, Jeremy, for a perfect presentation to show what a wonderful range of opportunities there are for specialists who want to work with addictions. So from my perspective, the term addiction medicine is used internationally, but it's much broader than what people would imagine by just using the word addictions. It looks even more widely at the general use and harm reduction across the community. And so addiction medicine offers an opportunity to do both primary, secondary, and tertiary prevention of harm. It looks at management of acute drug-related problems and the rehabilitation of people. Hannah, can you change the slide? we're doing a dual thing here with Hannah being hands-on and me just talking. I'll keep going anyway. There we go. So as I said, there's a wide opportunity for people from different specialities or within the speciality of College of Medicine. Rehabilitation, if we're interested in looking at that, it gives people an opportunity to take a very broad approach to practicing medicine, because we're going further than just the individual, and we're looking at the impact of trying to get people more socially integrated into the community, as well as just looking at their individual physical and psychological well-being. So the practice of addiction medicine is holistic. It deals with both the individual and the circumstances where they live and what their future might hold. And so for an addiction medicine specialist, it's really important that you understand the environment in which a person's living, understand the different roles that health providers can give. And so huge opportunity for collaboration across the spectrum of medicine. So the practice of addiction medicine can be divided into major perspectives. One of them is clearly the clinical perspective, which is where most people end up, but there are opportunities to work with a public health perspective, looking at addiction-related problems within the community or within your local setting, and also as advisors to support primary and secondary care providers when they have people that they're trying to assist, as opposed to pushing everybody into tertiary services. So although it's my belief that addiction management or treatment of addictions is every single medical practitioner's responsibility, and we do need to know something about how to do that, because the environment is becoming more complex and there are new tools and new techniques and knowledge available. We as addiction medicine specialists should be able to provide support and advice and information to those around us, and to utilize our comprehensive understanding to enable those that are managing people in their practices to do so better. So you can see from the presentation that Jeremy gave, there's the huge public health issue. There's a level of public strategy and planning at a government level, right down to understanding the molecular biology and the way that the brain is working with different substances. So it's a great opportunity for a range of specialists to become involved in addiction medicine. For instance, we heard the psychological impact, which is why many psychiatrists go and do the certificate of addictions. Physicians clearly have a very important role on managing the physical and psychological needs, and GPs, where people come to first be noticed. So there are opportunities in addiction medicine in both private and public. Since 2015, there are at least 15 Medicare numbers that private practitioners can use, but bringing in each group's unique experiences to cover the broad range of opportunities that an addiction medicine specialist can utilize. And I'll hand over to Hannah to explain how you can do this.
Thank you, Associate Professor Gail Robertson. If you are interested in applying for addiction medicine and how you could gain a fellowship in this interesting specialty program, there are two pathways that I will just very briefly describe tonight. The first pathway is for those who have yet to embark on a college training program. You would need to apply for adult medicine basic physician training job in an accredited training hospital after obtaining your general registration and completing your internship, and then applying to the College of Physicians. This is a 3-year program, including all the college's written and clinical exams. Once you have finished the 3 years of basic training and been successful in your exam attempts, you can then apply for addiction medicine as an advanced trainee. You can sign up for just addiction medicine or do a dual training program with one of the other specialties, such as general medicine. This is also where the second pathway joins the program. So if you have a fellowship already in another college, or a specialty of the College of Physicians. You can sign up for the 3 years of addiction medicine advanced training directly. So just to reiterate, Pathway 1 is 6 years of training, 3 years of basic physician training, then 3 years of specialising in addiction medicine. Pathway 2 is for those who already have a fellowship, and it's just 3 years of specialty addiction medicine training. The list of compilated fellowship programs is quite extensive, including emergency medicine, general practitioners, psychiatrists, intensive care specialists. If you are interested and are unable to see your college listed, please feel free to email addictionmedtraining@racp.edu.au to inquire about your specific program. Please note this is just a snapshot overview of the 3-year advanced training program. If you would like to find more in-depth information about the requirements and the training program, please visit the advanced training programs on the RACP website. All the slides from tonight's presentation will be sent out to you. I would now like to hand over to Natalie to wrap up this evening's program. Thank you.
Thank you, Hannah. Apologies for the delay. That concludes tonight's webinar. Many thanks to Jeremy and Gail and the RACP team for a great presentation. Next week, you will receive an email containing answers to all submitted questions, including those that were unanswered during the session, to ensure that everyone receives a response. Along with this, you will receive a link to our CPD to log your CPD hours, a PDF of the combined presentations, and a link to the event recording. As you leave this evening's webinar, you'll be given the opportunity to participate in an evaluation survey. Please consider completing this as it shapes future events that are offered by RACP. Also, a reminder that you can find information detailing the work the college is undertaking to support and advocate members on COVID-19 via the RACP website. A link can be found via the chat box. Other webinars that are being offered by RACP are also located on the RACP events webpage and by looking out for future email correspondence. Thank you for joining us tonight. Please watch out for your email and don't forget to leave tonight's webinar by clicking the Leave Meeting button on the bottom right-hand side of your screen. Good night.